All right, good afternoon, everyone. We're talking about triple PD as the diagnosis. This refers to persistent postural perceptual dizziness. I'm Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. We work a lot with vestibular disorders, functionally kind of with a different paradigm, so to speak, than your standard vestibular rehab and physical therapy. Not denigrating physical therapists. I have lots of friends who are physical therapists, but it's just a different way of looking at rehabbing peripheral and central connections within the nervous system that functional neurologists have. You can also say they're typically referred to as board certified chiropractic neurologists, and those who have a neurological or vestibular specialty in PT. Tonight, we're talking about triple PD. We say it that way. I used to say PPPD, but that confuses it with BPPV. So all of these, so to speak, all these names run together. So we're going to call this triple PD. And I'm going to talk about why I'm actually not a huge fan of the triple P diagnosis. I actually, maybe because I'm older compared to some of the newer people into the clinical world, but I liked the previous incarnations or designations of what is now PPPD or triple PD. So without further ado, we'll show this in the frame. And again, this is kind of the title of the article or title of the broadcast. Should we call triple PD psychophysiological dizziness? So psychophysiologic dizziness was throughout many of the textbooks. Dr. Robert Baloh, B-A-L-O-H, a very formidable vestibular researcher, kind of one of the top people in the world, has written several books, and he talked about, I think it was Baloh and Onrubia, talked about psychophysiologic dizziness being one of the most common causes of dizziness. And psychophysiologic dizziness is basically an entity where there's heavy anxiety associated with the dizziness, and maybe the anxiety is the underlying causation of the dizziness. Now, before we had the triple P diagnosis, triple PD diagnosis, we had different entities. We had something called phobic postural vertigo. Phobic postural vertigo is where if you were to go up on a ledge, or you were on the edge of a cliff, or you were at the top of a tall building or a lighthouse, and you would look down and you would have severe symptoms as though you felt as though you were falling and you were really dizzy, and maybe that dizziness stays with you for quite a long time after that event. That was referred to as phobic postural vertigo. We also had visual vertigo. So visual vertigo would refer to when we've all had that experience where you're in a bus and the other bus starts moving, you feel like you're moving. Most of us have had that. But visual vertigo is where there's a lot of visual motion. Maybe you're walking through a grocery store and the aisles, or you're looking at a freeway, and that all of a sudden makes you really, really dizzy. That's referred to as visual vertigo. And then there was the incarnation of chronic subjective dizziness, which was kind of psychophysiologic dizziness. And there are functional gait disorders. So researchers took all of these separate entities, and now we collectively call that triple PD. Now I'm going to hide that. Let's bring this one in because this is a nice slide. Again, actually, I haven't said it yet. This is a review article, lead author Popkarov. You can find it online. Here's the reference down at the bottom of the frame. And actually, maybe I'll do this. If you want to pause YouTube and you can enhance this region of the screen, you can see the citation. So how the Bharani Society has diagnosed or labels the diagnosis of triple PD, we want to look at a number of characteristics. Basically, you have to have one or more of the symptoms of dizziness, unsteadiness, non-room spinning vertigo on most days for at least 3 months. Now, we'll pause there. What is vertigo? Vertigo refers to the illusion of motion. So most typically, vertigo has the connotation for rotational motion, around a person or feeling as though they're rotating. That's typically what vertigo means when your doctor says, do you have vertigo or do you have dizziness? Dizziness is this nebulous sensation of you don't feel right. Maybe you feel like you're moving. Maybe you feel the environment's moving, but it's not per se rotational. But the true sense of vertigo as a label is the illusion of motion. So technically, if someone feels like they're rocking or bobbing, as do MDDS patients, Mal-Day-Barkman syndrome patients, and lots of times vestibular migraine patients, and good afternoon to everyone who's joining, they feel as though they're rocking and bobbing. That's actually technically vertigo. So you can have non-spinning vertigo, an illusion of motion, and that can be part of triple PD. Now, going further, the symptoms last for hours, but they may wax and wane. They don't have to be present all the time throughout the day. And they're provoked with specific exacerbating factors, namely being upright, so standing. Most typically, I guess you could be upright and seated, but typically they're upright. It involves active or passive motion without regard to the direction of the motion, and also exposure to moving visual stimuli. So you have to be upright. It's typically provoked by being upright, provoked by motion, active or passive, and or visual motion. So let's pause there. Let's compare and contrast this to Mal-Day-Barkman syndrome. So Mal-Day-Barkman syndrome, for those of you who don't know, is a condition where individuals are on a boat, most typically, or maybe it was a plane ride, and they come off of the boat or the plane ride and they have prolonged symptoms, feeling as though they're rocking and bobbing much longer than 7 days after getting off the boat. That can be normal. And typically it's lasting for months and lots of times years, where they just always feel as though they're rocking and bobbing. And most typically, their rocking and bobbing sensations are alleviated by doing something like driving in a car. So they're driving in a car, they feel better. Compare and contrast that to someone with triple PD. They lots of times when they're in motion feel worse. So they're upright, they're moving around, and they feel worse. They may be driving in a car and they feel worse with all the visual motion. So that's a key feature of how to differentiate triple PD versus something like Mal-Day-Barkman syndrome versus something like vestibular migraines. Typically, an interesting thing about triple PD is that it's triggered by a number of different events. So patients with BPPV, benign paroxysmal positional vertigo, where rocks, think of them as rocks, little pieces of calcium carbonate crystal, can be dislodged from a part of the inner ear, go to another part of the inner ear and the semicircular canals. And when a person moves their head or they lay down, then the crystals move, they have a higher specific gravity, and that causes the symptoms of vertigo. So BPPV, vestibular neuritis, can be triggers for PPPD or triple PD. So you can have a vestibular syndrome or condition that then triggers triple PD. In fact, I think they say some upwards of 25% of vestibular neuritis patients develop triple PD. And actually, I would say some references would say it's higher than that. I've read some studies that think it's around 50% of vestibular neuritis. That's where the one or both portions of the vestibular nerve are affected by a viral infection or autoimmune attack, causes sudden vestibular loss. There may be some recovery, but it involves rotational vertigo for hours, most typically, to days, nausea and vomiting, and it may slowly get better. Some people develop residual dizziness. The point I'm trying to make is that you can have a vestibular syndrome that triggers PPPD, triple PD. You can have an anxiety or panic attack that triggers triple PD. So you may have a medical illness that triggers triple PD. So a variety of different elements can trigger this condition we now refer to as triple PD. But even if the vestibular neuritis resolves or the BPPV resolves, the triple PD seems to kind of have a chronic course. Let me see here. What else do I have on the slide? Let's do it this way. Yeah, and then you also have to rule out that the symptoms of triple PD are not accounted for by another disorder. So it's a lot of discussion, and what do we take away from it? What we take away from it is that with the triple PD, folks, the commonality is, regardless of the first triggering event, whether it's a medical illness, whether it's a vestibular condition, whether it's a panic attack, is that there tends to be the onset of severe anxiety lots of times regarding motion. Lots of times gait is affected. So the individual with triple PD may have a characteristic gait where they're walking very cautiously. And when a neurologist or ENT checks them out, lots of times the tests for balance and other vestibular tests like the video nystagmography examination are normal. But this individual will walk as though they're walking on like ice, and they're very, very afraid. And it becomes what we call a functional gait disorder. Again, their symptoms can be triggered by visual motion, that's a big one, as well as passive motion. And it seems to be that this individual who has triple PD loses sight of where they are at relative to their surroundings. Within the brain, we have a very deep area that I don't feel is talked about enough anymore. It used to be talked about a lot, but I don't see it talked about enough for the triple PD patients. Deep down in your temporal parietal area, there's this other lobe of your brain that if we were to pull apart basically areas of your temporal lobe, you would see this area called the insula. It's called the parietal insular vestibular cortex, which is deep down in the center of the brain. The insula deals a lot with interoception. So the insula takes on signals from our inner ear. The insula talks to our parietal lobe to know what is going on with our joints and our skin. And when there's a dysregulation of signals to the insula, it can trigger anxiety. So a lot of vestibular disorders, namely, will trigger anxiety because there's this mismatch in the insula, way deep in the brain, for what's going on in one's body. So what they typically see with triple PD is that there's a visual dominance. So the visual cortex, let's see here. Okay, so your occipital lobe, how I can demonstrate well. Your occipital lobe is back here. The occipital lobe sends connections to other parts of the brain. We're going to have connections to the parietal lobe. We're also going to have visual processing actually in your temporal lobe. And so what we see with triple PD is that there's a visual dominance. And there also seems to be dysregulation of the limbic system relative to motion, i.e. there's poorer function of how the frontal lobes are gating the limbic system when we're walking. Simply to say that triple PD patients are visually dominant. They don't have good realization of where their own body is relative to a joint perspective, relative to a vestibular perspective. And then because of that, they develop tremendous anxiety with locomotion or moving. And the areas of the brain that should shut off that anxiety are not working as well. So hopefully you get that take-home point. And from that, the reason why I liked the previous nomenclature before the incarnation of triple PD was that I felt that it had more specificity to the individual. So we used to call it visual vertigo, which would immediately tell you as the patient, oh, maybe there's something going on with me visually in my visual part of my brain that's not working as well as it should. So that implied something. Same thing with psychophysiologic dizziness. That said, maybe there's an anxiety component that we really need to address. Dr. Below in his books would discuss how psychophysiologic dizziness patients lots of times would improve just by doing really vigorous exercise. Because by doing vigorous exercise, we would get more blood to the brain. When we're anxious, a lot of people don't realize that we tend to hyperventilate at a subtle level, so to speak. And that hyperventilation changes carbon dioxide concentrations in the body and the brain and results in a condition called hypercapnia, if I remember right, which then causes vasoconstriction. So a great way to fix that is to do vigorous exercise, cardiovascular exercise for 30 minutes once or twice a day. And lots of times that would improve the symptoms of someone with psychophysiologic dizziness. Someone with phobic postural vertigo may understand that, yeah, there's a visual component. When there's a depth perception issue, when I'm standing on something tall, maybe I don't realize what's going on in my own body. So that's why I liked those previous diagnoses. Whereas with triple PD, it's a nice conglomeration of symptoms, as you can see here, but I don't feel that it maybe tells you, the patient, as much about your condition. You let me know if you disagree. I would love to hear your thoughts. Okay, in terms of the medical model, a lot of it is focused on vestibular rehab. So the standard vestibular rehab exercises to kind of help the cerebellum to adapt, for the cerebellum to talk to the parietal insular vestibular cortex. Also medications to quell the anxiety. Have a lot of research in the world of chronic subjective dizziness. Before we called it triple PD, chronic subjective dizziness lots of times was mainly psychophysiologic dizziness. So in essence, there's a lot of evidence that boosting serotonin and or serotonin and norepinephrine has efficacy to calm the anxiety, probably because of what we know from other studies, in that it grows new brain cells. These medications grow new brain cells in the memory area, tending to shut off the fear center. Cognitive behavioral therapy, is discussed, doesn't have as much research behind it, but it's something that's commonly employed for the triple PD patient. In terms of the functional model, just take a quick sip here. Yes, we do focus on neurotransmitters, supplementation. We do focus on things like meditation and yoga and vestibular therapy. The vestibular therapy employed by functional neurologists, we have a little bit different of a paradigm, as I mentioned earlier. Where we're really trying with triple PD patients is to get their brain to kind of acclimate, so to speak, or to better learn where their own body is relative to their surroundings and to become less visually dominant. So that's a key characteristic of what we're working with. So for example, with a triple PD patient, I may put them in a weighted vest so that they have more compression of their axial skeleton to know what's going on in their body, so they have a better sense of where they're at and less visual dominance. So that's something I may work with. I may put a caloric in someone's ear and inject warm air into their ear to create a current in their ear to send signals to the opposite parietal lobe to give them some activation of their vestibular system to start teaching them out of being so visually dominant. So that's the type of logic that I use in working with a triple PD patient. So send me your thoughts. Let me know your thoughts on triple PD. Let me know if this was helpful or any areas you think that I need to address. Again, the triple PD patient is one who tends to feel worse when they're upright, moving around, active or passive motion, and visual motion makes them feel worse. They tend to be visually dominant, and they tend to develop, at least, whether anxiety triggered it or not, they tend to develop a lot of anxiety regarding locomotion or moving, ambulation, because of this visual dominance, because they don't really, their brain is losing sight of where they are at relative to their surroundings. All right, well, have a happy Friday, everyone, and I will talk to you later.